this. All right, that's good. So we're going to talk about Equinus and improved patient outcomes. These are my disclosures. This is a quote from Jim Amos in one of the last articles he wrote. We're going to talk a little more about his research here throughout this lecture, but I really like this quote to get things started. He said, "We are awakening to a new era of the understanding of the mechanics and function of the human foot and ankle. There is a simple and singular, usually silent and remote cause for the majority of non-traumatic acquired foot and ankle pathology, and mechanically, it creates cumulative damage to the foot and ankle through leveraged forces. In short, and in this author's opinion, Equinus is a primary mechanical common denominator that leads to the majority of acquired non-traumatic foot and ankle problems by indirect leverage means as well as direct forces along the posterior and plantar chain. There can be no more room for standard thinking that these resultant foot and ankle problems arise just because we are getting older, or we are obese, or they are just random, or that Equinus contraction is only part of the equation. Equinus is the equation." There are some people, though, who question if Equinus is just a natural variant within human beings, and they use this concept that, well, yes, every adult has a tight calf muscle, but not every adult has pathology. And that's kind of what Kevin Kirby said in this article in Podiatry Today, where he talks about seeing all these runners over a period of years, and they all basically have Equinus, but very few of them had any kind of pathology. So maybe Equinus isn't so evil after all. And this article in 2017 was a really controversial article by Jarvis. It was looking at root biomechanics and sort of taking to task each of the 5 tenets of root biomechanics. And they said a similar thing as Kirby in that most of the people in their study, 87% had Equinus or tight calf muscle, but none of them had any symptoms. So maybe it's just an irrelevant variation in foot alignment. And the problem with those two statements is they're not seeing the forest for the trees. They're not understanding the bigger picture of what's happening. And I'll explain that here in a minute to you. When we talk about Equinus, the starting point is we have to first talk about how to properly evaluate for it, because that will then help us define it. And then we can tell what's normal from abnormal. Then we can start talking about why it causes the problems it causes. First, this pilot study from GAT helped to clarify some of the problems with measuring. GAT has a PhD in England he wrote a 300-page thesis for his doctorate on just how to measure for Equinus. So GAT is very into Equinus, as am I. But this study that they did, I think, is a really important study. It looked at what is happening dynamically and how does that relate to what we measure statically. And they talked about how important Equinus is and how it causes a significant number of foot and ankle problems. And we really need to understand how to diagnose it clinically so then we can treat it effectively. We're all familiar with the Silfverskiöld Exam, checking ankle joint dorsiflexion with a knee extend and a knee flex to differentiate gastroc from gastroc Equinus. That's not really what's difficult. What's difficult is that there are 23 different methods to measure ankle joint dorsiflexion described in the literature. So that causes a lot of confusion. And the ankle joint dorsiflexion can vary between 8.5 and 10 degrees, depending on what position the foot is placed in, whether it's supinated or pronated, and that's just too much variation to have any reliability. The historic way we as podiatric surgeons have been taught through the root method is to put the subtalar joint in neutral, then lock the mid-tarsal joint, and then dorsiflex the foot with the knee flex and knee extended. That also has been shown to have poor inter and intra-rater reliability. What is consistent and does give reliable results is if you take the entire foot and you supinate it, that locks the mid-tarsal joint to only 2.5 degrees of motion, which is clinically insignificant. So all the dorsiflexion that's occurring is occurring in the hind foot. Now, we really can't separate out the motion from the ankle joint and the subtalar joint. So, probably some people like to get really picky about this. Probably the better term is hindfoot dorsiflexion as opposed to ankle dorsiflexion, but it's still isolated to the hindfoot. And that's what's occurring in the second rocker gait, the late second rocker gait before the third rocker starts. And that's what's important. And the other reason that supinating the foot is important is because that's also what's happening in the late second rocker gait when the pronatus longus fires. And we'll talk a little bit more about that and why that occurs. And so this is also replicating, this method of testing is replicating the mechanics of the foot functioning in the late second rocker gait when all this is occurring. When we talk about the positioning here on the top left, you can see the foot being dorsiflexed in a pronated position. On the top right is the standard root method, putting the subtalar neutral and locking the mid-tarsal joint. Both of those are not very reliable and also not going to give you consistent results. And you're getting a lot of false motion through the midfoot, which is not a true evaluation of what's going on in the hindfoot. In the bottom picture, you can see the examiners taking the entire foot, and I mean the forefoot and the heel both, and supinating it with both hands, and they're going to dorsiflex the foot. And that's what we need to start doing. And I like this to be a passive measurement. I don't want the patients helping me. So if they're engaging their anterior tibial tendon while I'm doing this, I'll ask them to just relax and let me do it, or you can push down on the tendon to take it out of the picture. I don't know what 2 kilograms of force is, but what I do know is I want it to be a firm in range of motion. So I'm going to go to where I kind of get a nice firm in range of motion. I really find reassurance when multiple authors come to the same conclusion. And Dayton wanted to look at this, and they wanted to compare it to a radiographic parameter. And Dayton thought that the best way radiographic measurement to compare Equinus evaluation was measuring the tibiotalar angle. And what they wanted to do was to measure this angle with the foot in supination and neutral and pronated. And they did it both radiographically, as you can see in A, B, and C here, and then also clinically. And they looked for any difference between those groups to show that, yes, the motion is occurring in the midfoot and not the hindfoot. So radiographically, there was no difference with the foot being supinated, neutral, or pronated. And so what that means is that that specific tibiotalar angle didn't change radiographically because the motion that when the foot is in an improper position clinically is all occurring in the mid-tarsal joint. And they confirm that because there's a lot of difference between the foot position, whether it's pronated to supinated of 13 degrees or so, or whether it's in neutral and supinated of about 9 degrees or so. And again, that's too much variation between those different positions. So what they have shown is radiographically, it doesn't matter because the ankle or hindfoot motion doesn't really change. The motion, the excess motion that we measure clinically, therefore has to be coming through the mid-tarsal joint. And because of that and the potential for error using the standard root method, Dayton also recommended using the foot, putting the foot in a supinated position and then dorsiflexing the ankle, because with that, we're getting reliable hindfoot motion and we're removing all of the mid-tarsal motion, just like GAT was recommended. And if you look at some newer articles, that also has that supinated position of the foot as they're dorsiflexing the ankle to lock the mid-tarsal joint to really isolate the amount of motion that's occurring in the hindfoot versus the mid-tarsal joint. Now that we know how to evaluate it, we can talk about how to define it. Really, the big question with defining Equinus is, okay, what does a static measurement that we're taking with the patient non-weight bearing mean in the late second rocker of gait before the patient goes into the third rocker of gait and the calf goes from eccentric contraction to concentric contraction, and really starts to wreak havoc on the foot if there's not enough dorsiflexion. Well, we know at that point in time that to move your body from behind your foot over the top of your foot and then forward, your ankle has to bend between 10 and 20 degrees. At least 10 is sort of the accepted minimum, and that's well accepted in the literature. It may even be more. It might even be up to 20 degrees, so somewhere between 10 and 20 degrees. In GAT, they use this Viocon system on patients and had them walk and look. So they measured their ankle joint dorsiflexion statically. Then they used a system to have them walk, and they looked at how much dorsiflexion was occurring at the ankle in the late second rocker, right before the heel's coming up off the ground into the third rocker, to see how much ankle joint dorsiflexion was actually occurring. And there were two groups. One had -5 or less of dorsiflexion. The other was -5 to 0. Again, that's with the foot maximally supinated. So those numbers may seem a little bit different. And what they showed was in the group of -5 or less, the amount of ankle joint dorsiflexion was about 4.4 degrees. And clearly that's not enough dorsiflexion in that, because if your body's going over the top of your foot and the ankle joint's being limited to 4.4 degrees prior to the heel coming up off the ground, and your body moving over the top of your foot, your body still moves over the top of your planted foot because of momentum. Well, if the ankle joint is being restricted in dorsiflexion and your body's still going to go forward, something has to give. And you can have proximal compensation or you can have distal compensation. And both of those have ramifications, and we'll talk more about those ramifications later. The other group between -5 and 0 had 13.9. Now, that still might not be quite enough, but it's clearly more in line with what we need from a normal standpoint to move the body over the top of the planted foot. Gat said it's sort of amazing that we've just accepted Root's definition without any evidence for decades, and also correlating the static measurement with what's happening dynamically. Additionally, the best way, the most practical way that we can measure ankle joint or hindfoot dorsiflexion is with a goniometer. And the ankle joint axis and the goniometer axis are not parallel. Therefore, those numbers are not exactly translatable. So understand that the measurement that we're getting is an approximation. It's not an actual measurement, but it's really the most practical way we can do it. And here you can see the axis of the goniometer is straight transverse. The ankle joint axis is going to be anterior dorsal distal to plantar proximal lateral if you just go from malleolus to malleolus, and those axes are not parallel, so you can't just translate the numbers, but it's really the most practical way of doing it. And with this information, GAT defined Equinus as -5 degrees of ankle or hindfoot dorsiflexion with the knee extended. I had a question about, is there a better tool that I would recommend than a goniometer? Unfortunately, no, there's not. A goniometer is still the most practical of the tools to measure dorsiflexion. Let's see how I can get this. How frequent is Equinus? This was an article. Oops, I'm back too far. I have this thing on my screen I can't get rid of now. This was a historic article from Hill that looked at that, and at the prevalence of equinus and the linkage to common foot pathology. And they looked at new patients that came in the office that had a foot or ankle problem. If they had just a skin problem, they were excluded from the study. And essentially, they showed that 96.5% of the patients with a foot or ankle pathology had an underlying equinus deformity. And Hill said, and this is a very important statement, that we should look beyond the specific complaint to the underlying cause. And frequently, ankle equinus is the root of the patient's foot problem, and that stretching is an effective way to treat it when equinus is an underlying etiologic factor. There were a couple quotes that Hill had in the article regarding orthotics and equinus. First, that treating the apparent biomechanical problems that have an underlying equinus deformity with a rigid functional orthosis is a major reason for unsuccessful orthotic treatment. That is 100% true. Two, equinus patients who receive orthoses as their sole treatment may not be capable of accepting orthotic control. That is also true. Three, a rigid orthotic will prevent the foot from pronating. The result is arch irritation from excess friction against the orthoses. That's not true. That's not quite what's happening. We'll talk about that in a minute. Excuse me. Jastifer also looked at the relationship between equinus contracture in patients with a foot or ankle pathology and asymptomatic patients or control patients. They measured it with this Iowa ankle range of motion device, which is a validated device. It doesn't exist on the market. It's just something that they had made and then validated it with a different study. They also used a goniometer, and then they also just eyeballed it too. So they had these two groups of patients, and they measured them three different ways. And in all three ways, it didn't really matter how they measured them. There was a significant difference between the patients with ankle joint with a pathology having much less ankle joint dorsiflexion than the control group that had significantly more ankle joint dorsiflexion. And this was the largest study using a validated measurement device to support the finding that patients with isolated gastroc contracture may be associated with foot and ankle pain. We don't pay enough attention to it. Root said it's the worst foot in the world is a fully compensated equinus deformity. Jeff Christensen described it as a profound causal agent in foot pathomechanics and frequently linked to common foot pathology. And then Hill, as we mentioned earlier, called it a primary causal agent in a significant proportion of foot pathology. Pierre Baruch is a foot and ankle orthopedic surgeon who was the editor of a foot and ankle clinics in North America. This whole edition was based on the gastroc. So every article was related to the gastrocnemius muscle. And he, in his introduction, had some really, I think, fascinating quotes. First, he said, looking for retraction of the gastrocnemius should be an essential part of the foot and ankle examination for practitioners, not just surgeons. And he's exactly right on that. Number two was, even though equinus has been recognized for 50 years as having an influence on the foot, only few practitioners routinely search for it. He's right about the second part. The first part about 50 years is wrong. It's actually been around much longer. John Joseph Nutt in Diseases and Deformity of the Foot, which is the very first textbook written on foot and ankle, described as you load the gastroc-soleal complex, you have a strain on the plantar supportive tissues. So when the calf muscle gets tighter, there's more strain on the plantar fascia, and that's plantar fasciitis is what he was talking about. He also talked about as you load the gastroc-soleal complex, you see a lowering of the dome. And by that, he means pronation or flattening of the arch. And he talked about the linkage between equinus and plantar fasciitis and pronation syndrome over 100 years ago. So this is nothing new. We just haven't been giving it the attention it deserves. He also said in the conclusion of his introduction that I hope you will be convinced of the importance of this and no longer do without. I think an interesting question is, okay, well, why is it that pretty much every adult has equinus and so few children have equinus unless they have a pathology like a pediatric flat foot? And we're talking about non-neurologically based equinus here. We're talking about biomechanical equinus. So I'm not talking about kids with cerebral palsy. Those are more neurologically based. So Amos put forth some reasons that can maybe explain this. First, the law of Davis explains a lot of it. And the law of Davis says over time, soft tissue contracts to the shortest length possible. So particularly with aging and decreased activity levels, our calf muscle is not being maximally stretched out whenever we're out as children running and jumping and really taking the stretch point of our calf to its fullest stretch point. We're seated, we're at desk, we're not doing that kind of activity level, so the calf shrinks because of that. Number two, recent changes in activity. Let's say you rupture your Achilles tendon, you're put in a plantar flex cast, your Achilles tendon heals back fine, but it heals back tight now. So you're going to have to get it stretched out because of the position the foot was placed in while it was healing. Number three, athletes. Athletes tend to develop gastroc soleal equinus versus straight gastroc equinus as well, especially running-based athletes. And that's because the running gait cycle essentially is the knees constantly flex during the running gait cycle. So I've been the team podiatrist for the Indiana Pacers for about 28, 29 years. And I think every player has equinus. And it's because if you think of a professional basketball player, for example, they're just running all the time. That's all they do is run up and down the court. And as their calf hypertrophies, that also makes it tight, but also that constant position of the knee being flexed with the foot never being maximally dorsiflexed leads to shortening of both the gastroc and soleus. That's why running-based sport athletes tend to have gastroc soleal equinus. There are some reasons not related to the law of Davis. First, just physiological changes that occur in the muscle tendon with aging, and particularly collagen and connective tissues become less pliable. Two, genetics. Some people are just tighter than others. Three, bone muscle growth mismatch. And this applies to kids, particularly who are developing apophysitis. And it's been demonstrated through research that 100% of kids who have apophysitis develop or have an associated equinus. And it's also been well established in the research that the tibia and fibula grow faster than the gastroc soleal complex. So who gets apophysitis? It's usually kids who are active, but also going through a growth spurt. And that's one of the things that you should ask the parents. And I always do ask the parents, you know, is your son or daughter going through a growth spurt? And oftentimes they are. And what happens is the tibia and fibula are growing faster than the calf muscle. That makes the calf muscle tight, which then causes a traction apophysitis on the calcaneus, which is what Sever's disease is. I think really the key, though, to the explanation of the difference in equinus in adults and children is reverse evolution. And reverse evolution basically comes down in a nutshell to between 2 and 3 million years ago, we went from primarily quadrupedal gait to bipedal gait. And for us to walk on just our legs instead of walking on our arms and hands, our calcaneus had to drop down 70 degrees to get flat on the ground. For our calcaneus to move down 70 degrees to get flat on the ground, certain muscles had to elongate and certain muscles had to shorten. The muscles that had to elongate are the gastroc soleal complex, the hamstrings, and the hip flexors. The muscles that had to shorten are the quads and anterior tibial tendon. This change in our gait pattern occurred later in the evolutionary process. And because of that, as we get older, those are the first muscles that tighten up on us. And that makes a lot of sense to me. And anybody who, knows that as you get older, your calves and your hamstrings and your hip flexors are really tight, and it's a real fight to keep those stretched out. And I think that this reverse evolution, and it's also called the predilection pattern, explains the difference in rates of equinus between adults and children very elegantly. Amos said the things that we think cause foot or ankle pathology have just a causal relationship and little of any direct relationship, and that the singular really cause for most of the foot and ankle problems that we see on a daily basis is contracture of the gastrocnemius. And this is where Kirby gets it wrong, and this is where Jarvis in their article gets it wrong. It causes incremental damage to the foot and ankle. And what is happening is this damage is occurring incrementally, just small little damage. And that eventually is going to lead to a tipping point where you go into a pathological state. So you may see the patient prior to them going into that pathological state, but that doesn't mean that this abnormal force and stress and strain isn't occurring, causing damage, because it is. And you're just seeing them at a particular point in time before they have reached that tipping point into a pathology. And that's where they're getting it wrong. And the literature is really robust on the association of equinus with various pathologies. And if you are treating any of these pathologies, which are popping up on the screen now, would have all been linked to equinus as a potential cause, then the treatment for that pathology, the overall treatment, must include treating tightness of the gastrocnemius. Otherwise, you're not fully treating the problem. So for heel pain, for example, there's 50 or 60 articles that link those together. I keep this running list, and I haven't updated for a while, so it's probably more, but I'm up to like 225 articles that have linked these 35 to 40 different pathologies in the literature together. And if you have these problems and you have an associated equinus with it, it is mandatory that you treat that equinus as part of treating that problem. So yes, you may have a forefoot callus, and yes, you're going to trim it or whatever, but you should also be treating the equinus that's contributing to the forefoot callus, because we know as the calf muscle tightens, it causes more pressure on the forefoot, which is contributory to the development of that forefoot callus. Equinus biomechanics. So why does so much destruction occur when we have a tight gastroc? And there's some really great articles that sort of tie all this together really nicely. First, Thorson in 1995 they took cadavers and they pulled on different tendons to see which tendons elevated the arch and which tendons flattened the arch. In the sagittal plane, they used the talo first metatarsal angle. And as they pulled on the Achilles tendon, it was by far the primary arch deformer. And the more you pulled on it, the more the arch flattened. It was very clear. The primary arch augmenter or elevator was the windlass mechanism. And really, it's interesting if you look at this graph, it elevated the arch more than all the extrinsic tendons of the leg into the foot combined, way more than all those extrinsic tendons combined. So that shows you the vital importance of the windlass mechanism and why it's so important not to cut it. In the transverse plane, it's a little bit different, and this is talonavicular alignment. Again, the primary deformer by far is the Achilles tendon. So the more you pull on the Achilles tendon, the more it flattens down. Here, the posterior tib becomes a primary augmenter in the transverse plane. Even with continued loading, the windlass mechanism elevates the arch in the transverse plane as well. Thorson did say that the plantar fascia has an important dynamic function and that dividing the structure should be tempered by this data, which is absolutely true. Jeff Christensen wrote a series of articles in the late 1990s, early 2000s that are really historic, in my opinion, and should be mandatory reading for everybody that treats a foot or ankle. What they did is they took cadavers and they put a sensor on the first metatarsal, the first cuneiform, the naviculum, and the talus. And they, in each of the different parts of this series, they did different things to the foot to see how it affected the medial column and each segment of the medial column. So the first part, they took the peroneus longus and they pulled on it to see what happened to the first metatarsal, first cuneiform, and naviculus. So in the frontal plane, as you pull on the peroneus longus more and more, the first metatarsal, the cuneiform, and the navicula all showed increasing eversion the more you pulled on it. In the transverse plane, there's increasing adduction of the first metatarsal and abduction of the cuneiform and naviculum. In the sagittal plane, there is increasing plantar flexion of the first metatarsal and cuneiform and reciprocal dorsiflexion of the, or increasing plantar flexion of the first metatarsal and cuneiform and increasing dorsiflexion reciprocally of the naviculum. And here you can see the peroneus longus coming beneath the metatarsal joint into the plantar lateral aspect of the first metatarsal cuneiform joint. And the peroneus longus, kind of under the medial column under the influence of the peroneus longus, acts as a series of links. And what is happening in this late in the second rocker of gait, it stabilizes the medial column by everting the medial column of the foot into the central column of the foot. It's stabilizing the metatarsal joint by everting the medial column of the foot into the central column of the foot to lock the metatarsal joint. And this is how the foot gets converted from a mobile adapter heel strike to a rigid lever in the second rocker of gait going into the third rocker of gait, and allowing you to propulse forward. You can't propulse forward very efficiently or walk forward very efficiently on a loose bag of bones, which is what's happening at heel strike to absorb shock from heel strike. But then your foot has to be converted to something that you can push off of. And that's what the peroneus longus does. It also supinates the hind foot to increase the rigidity of the lever arm. And the plantar fascia and peroneus longus work together to help prepare the foot for propulsion, to convert it from being a mobile adapter to a rigid lever. And if you have a deficit on either the peroneus longus or the plantar fascia, that's going to cause a pathological situation where you're having abnormal stress and strain on subordinate structures. So in part 5 of their study, what they did is they pulled on the Achilles tendon with increasing load. And what they noticed was that peroneus longus did not do its job. So it wasn't everting the medial column of the foot into the central column of the foot to lock the metatarsal joint late in the second rocker before the heel comes up in the third rocker of gait. That led to unlocking of the metatarsal joint, which led to hypermobility or instability of the arch, and specifically flattening of the sagittal plane in the sagittal plane at the navicular cuneiform joint. And I really want you to think about flat foot x-rays going forward as you look at them, and look for the NC sag. And there's if the foot's bad enough, there's always an NC sag. And nobody really ever asks why. Well, why is there always an NC sag on these flat foot x-rays on the lateral view? And it's because of this. And understanding that and the consequence of it is important when we start to talk about how to treating flat feet non-surgically with orthotics. And this goes back to that statement by Hill, who said that the orthotic limits pronation and causes friction. And that's why patients have trouble with orthotics when they have equinus. Well, not quite. What's actually happening is the calf muscle's tight. It's driving the arch as the body then goes forward over the plantar foot. For the body to move over the plantar foot when the calf is tight, muscles tight, and not allowing the ankle joint to dorsiflex, in order to compensate for that, the navicular cuneiform joint is getting driven downward, and the foot is driving into the orthotic, specifically the medial flange. And then that's when patients come in for a follow-up visit on their orthotics saying that the arch is too high in the orthotic. The arch is not too high on the orthotic. The lab didn't just randomly make it too high, or your cast didn't make it too high. It's because they have this deformity from the leg that's influencing the foot, that is not allowing the foot to accept the control it needs. And if you can remove that deforming force from the leg onto the foot, then the foot can accept the support it needs, because the arch is no longer being driven down through the NC joint by the tight calf muscle. So specifically, you see plantar flexion of the talus and navicular and dorsiflexion of the first metatarsal and first cuneiform. And Christensen said that and this kind of goes back to Kirby's statement and Jarvis's statement. In clinical practice, the early destructive influence of Equinus is often not appreciated. Again, it's this accumulative damage. So we may not see a pathology, but the destructive influence is still there. It is still happening. You just haven't reached a tipping point where you've gone into a pathological situation. Instead, we're usually faced with the end results of Equinus effects. And this goes back to, is it better to prevent a problem than to treat a problem? And if we do treat a problem, we want to treat it sooner rather than later. It's much better in all circumstances to prevent a problem from even occurring. So we know that this is causing a pathological situation. But even though they haven't gone into a symptomatic state, we should be treating it. And if you watch this video, this is from Paul Scheer, the late Paul Scheer. The top foot's a normal foot, the bottom foot's Equinus. So watch the NC joint on the bottom foot here compared to the top. Watch how the tibia, as it goes over, rolls over the talus, and now the NC joint goes down to allow the tibia to move forward over the talus. And from the coronal view or the hindfoot view, watch how the NC joint is going down, but the effect of valgus moment occurring on the hindfoot, how the heel goes into valgus compared to the top. And then in the forefoot, watch how the first metatarsal goes up and into pronation. And we talk about this triplanar component of hallux valgus. Well, here it is. Look at the axis of the first metatarsal deviate as the NC joint is driven downward. And I'm just going to let you watch those again one more time. So NC joint here in the sagittal plane getting driven down as the tibia moves forward over the talus to compensate for the restriction in ankle joint dorsiflexion that's occurring as the body moves forward over the foot. Now, from the hind foot, as that NC joint is being driven downward, the calcaneus then gets pushed into valgus or goes into valgus. And then in the forefoot, watch the sort of forefoot varus deformity develop, but also watch the rotation of the first ray go into a pronated frontal plane component, as well as getting elevated and increasing the transverse plane deviation from the second metatarsal, which is where we get a bunion from. A lot of this is related to the subtalar joint range axis too. First, we can stand in balance without falling over because the center of pressure from the ground reactive forces, which is normally located at the second metatarsal cuneiform joint, is creating a dorsiflexion moment. So it's pushing up. Our calf muscle is trying to push down. And, the reason we don't fall forward is because of those ground reactive forces pushing up. With Equinus, that center of pressure moves distal and lateral from the second metatarsal cuneiform joint. So now it's moving farther away from the subtalar joint axis. The subtalar joint axis basically goes from the posterior lateral corner of the calcaneus right through the first metatarsal normally. That's the normal subtalar joint axis. The relationship of those two forces, the center of pressure and the calf muscle, and their distance from the subtalar joint axis, as long as they're similar, they're going to offset each other because the center of pressure is lateral to the subtalar joint axis. It's creating a pronation moment. The center or the gastrococceleal complex inserts medial to the subtalar joint axis, so it's creating a supinatory moment. And if those distances that those two forces are from the subtalar joint axis are similar, they offset each other. So in this case, they're pretty close. The gastrococceleal complex inserts more along the kind of medial back of the heel, more so than the lateral portion of the posterior heel. So its distance is very similar in this case to the center of pressure distance from the subtalar joint axis. The problem lies when we have a medially deviated subtalar joint axis, where now the center of pressure is significantly farther away from the subtalar joint axis, creating a significantly higher pronatory moment compared to the supinatory moment that's associated with the gastrococceleal complex. So this is going to cause more pronation of the foot. This is going to cause a greater pronatory moment on the foot. The opposite can be true in a high arch foot. And this is the reason patients with a cavus foot that is non-neurologically based can get worse. And that's all related to this. Now, fortunately, not many cavus feet have a true equinus. They have a pseudo equinus, but there are a few that do have equinus. And if they have a really laterally deviated subtalar joint axis, and now the center of pressure either lies on it or medial to it, if it's medial to the subtalar joint axis and the gastroc complex is also inserting medial to the subtalar joint axis, they're both creating a supinatory moment on the foot. And this is how the arch can elevate with time in a patient with a high arch foot that is not neurologically based. So there and there. Christensen said the author strongly recommend careful and clinical assessment and appropriate treatment of equinus with patients with biomechanical deformities affecting the first ray and midfoot. We know from different studies that as the Achilles tendon gets tighter and tighter and tighter, that center of pressure that we just talked about and that is so important moves more distal and more lateral. And because of the movement of that center of pressure distally and more laterally, the pressure on the forefoot goes up as the calf tightens, the pressure on the heel goes down, and also the pressure on the midfoot goes up. And this is really important when we start talking about our diabetic patients and diabetic forefoot and even midfoot ulcerations, when we start talking about tendon balancing to reduce pressures in those patients. We also know that we get total arch deformation, we get increased arch deformation as the Achilles tendon tightens as well. So Amos looked at this with slow motion photography to look at the gait cycle to slow it down sort of frame by frame. And again, I tend to lean more towards orthopedic surgical biomechanics than podiatric biomechanics. So I like the terms rocker, so that may be confusing some of you, but heel rocker is just heel contact, ankle rockers, mid stance, forefoot rockers, just toe off. It's the same thing, but I like the way the orthopedic literature sort of puts gait in relation to our surgical treatment. I think it's a lot more, it makes more sense to me. And I think we should be using the same biomechanics that we do surgically with what we do conservatively. So Amos talked about these direct forces that are associated with a tight calf muscle, which are very understandable. They're all, as the calf gets tighter, there's going to be more force on the gastroc, the myotendinous junction, the Achilles tendon insertion, the calcaneus, and the plantar fascia. Those things are all directly related to the calf muscle. Then there are these indirect forces that we talked about, that when you have tightness of the gastroc, that second rocker is limited, particularly late in the second rocker as the body's moving over the top of the foot, which he calls the passenger in this statement, which is just the body moving over the planted foot. So the tibia rolling over the talus. That leads to increased leverage forces upon the foot and ankle, which cause stress and strain on joints and ligaments and tendons, which causes pathology. And see, the problem with saying that all adults have equinus, but hardly any of them have a pathology means that equinus isn't pathological, is you're ignoring this increased stress and strain on these subordinate structures. Watch somebody do a Lapidus, or if you're a student, or when you can scrub in a case, and really take notice on those dorsal first metatarsal cuneiform ligaments. You want to talk about metatarsus primus elevatus? Well, look at those ligaments, and look how sort of unimpressive those ligaments are. And imagine this incredible force that's occurring due to a tight calf muscle, and those very unimpressive ligaments trying to prevent the first ray from dorsally elevating. They can't. There's just no way that they can do that. So eventually they're going to give, then you're going to get metatarsus primus elevatus. So you're relying on these subordinate structures, which just cannot withstand that kind of force. So here's a patient with posterior tibial tendon dysfunction, and you can see the first rocker, second rocker, and third rocker. And if you look at the picture on the left, that's in the second rocker of gait, and you see a fourth rocker develop, and that's right where Jeff Christensen said it would occur. It's in the navicular cuneiform joint, and you see a downward positioning of that joint with the first cuneiform getting elevated, the talus and navicular getting plantar flex. And then as you go into the third rocker where the calf muscles contracting, bringing the heel up off the ground, you see that third rocker worsening, that angle getting higher. And that's where you get this abnormal stress and strain. So Amos showed that this only occurs, it only lasts for about 1/10 of a second, which doesn't sound very long. But the problem is how many steps a day do you take over how many years? So that's where you get this occult, unrecognized overuse imbalance that leads to damage of the foot or ankle. And that's the problem. Additionally, what happens at that very moment when the ankle joint's being limited in dorsiflexion, the body's moving over the top of the foot, the knee goes into full extension, which is the worst thing that could happen at the worst time, because that increases the direct and leverage forces on the foot and ankle by twice the force and half the time. So basically think that you're getting pulling on both sides. That's what's occurring. You're getting pull on both sides, which is sort of magnifying the strain and stress on these subordinate structures that we're trying to rely upon then to try to salvage the foot mechanics, and that's not going to happen. And then Amos said that this being human places us at risk for developing acquired non-traumatic foot and ankle problems, and then damage is mediated through our unique anatomy and the gastroc that tightens for a number of reasons, which we talked about previously. So how do we treat it conservatively? We're just going to go through conservative treatment real quick. I probably won't have time to go through the surgical treatment. There are a few questions we have to answer when we're talking about non-surgical treatment. First is, what stretches? Does the muscle stretch? Does the tendon stretch? Does it matter? This is a very controversial topic amongst physiologists. And some people say the muscle stretches, some people say the tendon stretch. I think it's still probably up for debate, but this study looked at that. And they also looked at how range of motion changed with stretching. And really what the authors found is range of motion improved significantly with stretching, number one. Number two, the tendon didn't change. Number three, the muscle didn't change. So what allowed that increased range of motion? The authors felt it was probably most likely due to altered tolerance to stretching by the nociceptive nerve endings, but there was no effect on the muscle or tendon units. Like I said, you can find articles that debate this back and forth. This is from Clinical Biomechanics, which I think is a very strong journal, and I really like this article it sort of, I think, paints the most accurate picture of probably what's happening. How long should you stretch each day? It's just really unclear in the literature. There's no real good guidance, unfortunately. The best article that we have is Radford's article, which was a meta-analysis on stretching. The problem was only 5 articles met their inclusion criteria. And because of that, they couldn't make any definitive statement. They just said that, look, the longer you stretch, the more the range of motion. And that makes sense to me. That's just common sense. So the more you stretch, the better the range of motion. And Radford said that calf muscle stretching provides a small but statistically significant increase in ankle dorsiflexion, and it is recommended. And when I looked at those numbers from the study a long time ago, when it came out in 2006, I realized that, it doesn't appear that the numbers that they're showing in the study are going to be enough to get patients to where they need to be in most circumstances. So what I did is I started using 1 hour. I doubled that 30-minute mark to get, I'm hoping to get 6 to 8 degrees of dorsiflexion. And that has worked very well for me over the last 20 years or so, 14 years, whenever this came out. And that's what I still use. And that may be too long. 30 minutes might be enough, but nobody has really clarified that yet. If the position of the foot matters when we're evaluating for Equinus, does it matter when their patient is stretching? And this is a really important question, because this really applies to especially manual stretching, the runner stretch specifically, whether you're stretching with the foot in a pronated position or a supinated position. And this article by Johansson, they had patients stretch in pronation and supination, and both feet started at the same number, which is important for a thing we're going to talk about in a minute. But the first thing they noticed is when patients stretched in pronation, their knees were more flexed compared to stretching and supination? Well, that's important because the gastroc is what's tight most of the time, and you have to have the knee extended. And the only way you can have the knee extended is if you externally rotate the tibia. And the only way you can externally rotate the tibia is if your subtalar joint supinates. And that's called the screw home mechanism. So the subtalar joint supinates, the tibia externally rotates. That allows the knee to go to full extension. That's important. Number two, as you stretch with the foot pronated, significantly more motion is occurring through the mid-tarsal joint. That is also important. We do not want that motion occurring in the mid-tarsal joint. We want all that force directed to the hind foot. And we want that motion at the hind foot so that it's stretching the calf muscle and not just dorsiflexing the midfoot. And we really basically never want the midfoot dorsiflex. That's usually never a very good idea. So it also helps, that will also cause flattening of the arch, which is not what we want. So the idea is to stretch in supination. So dorsiflexion occurs at the hind foot and externally rotates the tibia, locking the knee into full extension via the screw home mechanism. This article on runners had them stretch, and they started at 5 on the right and left, both sides and the same. And what they showed was 8 weeks of stretching improved range of motion by 200%. So you can have a significant improvement in range of motion. And an interesting sort of side note, and I probably don't have too much time to go into this, but as the runners got more stretched out, their running times improved. And this is a really important concept. People who deal with athletes, especially elite athletes, think that static stretching reduces explosiveness. Is that wrong or is that right? Well, just kind of real quickly, I'll go through this, but it's sort of misunderstood is the best way to describe it. Static stretching right before an athlete participates in their activity reduces strength. So it does decrease explosiveness. So if LeBron James does static the wall stretch, the runner stretch against the wall for too long, right before he plays, he cannot run as fast from one end of the court to the next, and he cannot jump as high. That's true. However, if he does static stretching not related to performance, so he does stretching the night before his next game or the morning before he plays 8 hours later at night, that actually causes muscle hypertrophy, which has been shown to improve performance by a small percentage. That's why when you go to a game, whether it's a pro football game or a pro basketball game or whatever, you'll see athletes doing dynamic warm-ups where they're kind of skipping and doing walking lunges and things like that versus doing a lot of static stretching. You can do static stretching, but if you need to keep it below 30 seconds per muscle group before you play. Once you get above 30 seconds per muscle group, that's where you start to cause muscle weakness. But if you do static stretching not related to performance, you actually cause muscle hypertrophy, which can increase strength. And interestingly enough, the 3 most common running related injuries are Achilles tendinopathies, plantar fasciitis, and medial tibial stress syndrome. The number 1 risk factor for all 3 is Equinus. So if you can reduce the risk of those things from happening and improve performance, every professional athlete, every serious athlete should be doing static stretching not related to performance. 100%. This concept that, oh, athletes need to have a tight calf muscle you're going to reduce their springiness. That is total and utter bullshit. That is not understanding what's going on. Like I said, the wall stretch isn't bad. It's just the problem is compliance. Let's just say it's 30 minutes per day with a runner's wall stretch. But it's going to be 30 minutes per day per leg, first of all. And secondly, most of the literature talks about taking 6 weeks to stretch out the calf. I think it probably takes 8 to 12. But there's just so many ways to do it wrong and only one way to do it right. First, if you bend at the hip too much, that's a problem. If your back knee's bent, if your heel's coming up off the ground, you have to stretch in supination instead of pronation. If people just cannot do this right, they will not do it long enough, and they will not do it consistent enough to make it an effective modality of treatment. Night splints, the problem with night splints is you sleep on your side with your knee bent, so they do nothing for the gastrocnemius. It's a complete waste of time. If you try to have a patient use a night splint and keep their leg straight, they're going to do what's on the far picture on the left, or maybe try the right, which is still not good enough because the knee has a natural state of flexion. And in order to maximally extend the knee and dorsiflex the ankle, it's uncomfortable. You almost need to be forced to do it. And you need something to hold your knee to extension while it's dorsiflexing your ankle. That's why, even though that's not bad, it's just not good enough. Dorsal night splints are worse because of all those same reasons. Plus, they allow the forefoot to plantar flex relative to the rear foot, which just adds to this the ineffectiveness of the treatment. Ideally, with stretching using a brace, you'd want a brace that goes above the knee to lock the knee into extension, which is critical, number one. Number two, we just give patients night splints and tell them to pull as tight as they can. What happens is you overstretch them and you give them Achilles tendonitis. Well, you should have something that has controllable hinges at the ankle to correlate to what's happening with the treatment, the clinical exam. So, controlling treatment based on clinical exam is important, and that's what hinges at the ankle joint can do. And thirdly, it's important to stretch in supination. By engaging the windlass mechanism to supinate the subtalar joint, to externally rotate the tibia to lock the knee into full extension. That's why that's important. So if you have a patient with heel pain on the right side but not the left, do you have them stretch the left? That's an important question. And studies have shown that the right and left are the same, like Macklin and Johansson, which we talked about earlier. I have a paper that's going to be published next year on the bilaterality of Equinus. Also, the pennation angles, which are the muscle fiber angles of the lower extremity muscles, are always the same on the right and left side. So they're always going to be the same unless there's a reason for them not to be the same, like they've had a prior injury or surgery or something. So if you stretch one side without stretching the other, basically you're creating a functional limb length inequality, which is going to cause back and hip problems. So stretch both sides at the same time. This is that orthotic Equinus war where you get the NC sag because of the deforming force of the leg onto the foot. And then you can see the orthotic pushing the arch up, and you can see how those two would fight each other and the patient would feel like the arch is too high. So particularly with children, I think it's important. Adults, you can kind of simultaneously do it as the orthotics are being made, but kids, always tell parents that if we're going to treat their child conservatively, non-surgically, we're going to stretch them first and then get them in orthotics. That way they can tolerate the orthotic like they need. The shoe drop's also an important concept, particularly if somebody's wearing a higher heeled type shoe. And shoe drop is just the difference of the height of the heel and the forefoot. It's more recognized in running shoes, but it also applies to dress shoes too. I like patients to be between a 4 and 8 millimeter drop to start with. So some shoe companies get this and some don't. And the ones that don't are like 14 or 16 millimeter drops. And those patients are wearing for 8 to 10 hours a day or 12 hours a day. They're fighting the 30 to 60 minutes of stretching that you're doing that day to get their calf muscle stretched out. So you need to discuss the heel height of your patient's shoes to make sure that it's in that kind of 4 to 8 millimeter difference between the forefoot, whether it's a dress shoe or a running shoe or a gym shoe. So my recommendations for Equinus management are 1 hour per day seated upright, because remember, if we go back to that whole concept of reverse evolution, hamstring tightness is a problem. Hamstring tightness has been associated with plantar fasciitis in the literature with 3 or 4 articles. So I have the patients wear the brace that I prefer for 1 hour a day seated upright. That way they're stretching their gastrocsilial complex and their hamstrings simultaneously. And if you actually elevate the leg a little bit while you're doing that, like with a pillow or a recliner, that will stretch the hamstrings even more, and you really, really feel it in the hamstrings. I stretch both legs at the same time until the Equinus deformity has resolved, if they both have Equinus. I check them monthly. The brace that I use has 3 settings on it, so I keep them at each setting for a month, each hinge setting for a month. And then once they go through all 3 settings, and it's going to kind of overstretch them just a little bit. And then once they're done, because of the natural process of aging, the anatomy of the calf muscle, and walking upright, if you stop stretching at that point when they're fully stretched out, they are just going to tighten back up. So you have to then transition what I call active static stretching to maintenance therapy. It's much easier to keep somebody stretched than to get them stretched. So maintenance therapy is just preserving the stretch. And for me, for most people, that's 2 nights a week with the brace that I use for an hour instead of every day. So like Monday, Thursday for an hour, that keeps them stretched out really nicely. There are 3 groups of patients that require um, more stretching, more active stretching for a maintenance therapy. One is athletes. So, a serious running sport based running running a sport with running associated with it. And there are 2 that have a metabolic component to their Equinus on top of the biomechanical component. And those 2 are diabetics. Diabetics have glycosylation of the Achilles tendon, which leads to disorganization and shortening of the Achilles tendon, and rheumatoid patients both have kind of a metabolic component to their biomechanical component of their Equinus. So on athletes, diabetics, and rheumatoid patients, I have them go Monday, Wednesday, Friday. So 3 nights per week for maintenance therapy. There's my contact information if you ever have any questions about this. This is a QR code. If you want a PDF of my lecture, you just have to hold your phone up to it and turn your camera on. And it'll send you a link from my Google Drive. If you have any questions, I can answer some questions real quick. Otherwise, everybody have a good day. I did record this video and I will post it on my YouTube channel for later viewing if you'd like to watch it again, or if you have friends who were not able to join us live and you want to let them know about it. This is part of the APMSA lecture series that I'm trying to help develop with the APMSA for the 3rd and 4th year students. And if you can kind of help spread the word, if we can get this interest level up, I can get other colleagues that I know well across the country to participate and hopefully generate a really nice lecture series for the 3rd and 4th year students. Well, thank you. Have a great day. And let me know if you have any problems. You're welcome, Miriam.